everybody. Welcome back to the Girls with Guts podcast. I'm your host, Nicole D'Ambro.
And I'm Elena Martella.
And today we're going to be talking about a topic that is near and dear to my heart. Strangely enough, the female hernia.
Very strange, yes.
It's so weird, but it's actually what led me to getting my diagnosis of cecal volvulus. And the doctor who discovered both is world-renowned hernia specialist, Dr. Shirin Towfigh of Beverly Hills, who's my doctor and my angel. So I am so thrilled to introduce her to you, Elena.
And I'm so excited to meet her.
Yeah.
It's like your saving grace, you know? Everybody has that doctor that, you know, they always think of as, wow, this is my lifesaver. And I'm so excited to meet yours.
Yeah, me too. Just shout him out. Your doctor's name again is?
Dr. Reichman. Dr.
Yes.
Frederick Reichman. And then also alongside him, Dr. Charles Park.
Awesome. Mm-hmm. Great doctors just make all the difference. And I'm so excited to talk about them.
Yeah. I have one more shout out. My current surgeon, Dr. Janice Rafferty. So
yes.
we have a whole bunch of them. So
we're adding them. Love me a good doctor.
Hopefully we don't need to expand the list. I'm thinking that we're in the This is a list we don't want to keep moving forward with. So hopefully we're at that, you know, end of the list. Boom.
At least for these kinds of doctors. Yeah.
Yes, exactly.
We'll get to the other ones later. But yeah, so what's new with you, Elena?
Not much is new at all. I guess I had that nematosis, which we spoke about. And I was on a liquid diet for that. So my main thing right now is just trying to gain the weight back, because obviously when you're on a liquid diet for a week and a half, you're going to lose weight. And so that's kind of where I'm at right now. And with our intestinal issues, it can be hard to put weight back on. So it's a slow process. I do feel a little uncomfortable, but I have faith we'll get there. We will get there, but in due time. So it's just trusting the process, trusting the journey, going forward. But other than that, man, life is great.
Well, can you explain to people like what pneumatosis is? Because I had no idea. Like, what does it feel like also?
Yeah, so it's just a huge cramping pain in your intestines, and you kind of blow up. Like your stomach gets so bloated, you get very distended. And what it is actually air that gets trapped in your intestinal wall. And, you know, there are some people suspect that it's because of ischemic bowel that you might get it. But in my case, that's not it. It's called benign pneumatosis. It just happens out of nowhere. No rhyme or reason. It just happens. And I actually had one previously, let's see, like 10 years ago. And it was ironically 9 months after an emergency surgery that I had. And then this one that I just had was 9 months after an emergency surgery. So it's kind of interesting. It's an interesting pattern. It's almost as kind of like it's my healing pattern, maybe. That's, you know, what I'm thinking. So yeah,
that's really interesting, because I've never heard of that. I haven't experienced that. I don't know anybody who has, but you know, that's something to be aware of if you're going to get emergency intestinal surgery of any kind. That kind of thing could happen. So I think that's valuable to share with people. Also, can I just say that I think that your intestines just decided that since we started this podcast that they would make several guest appearances. Like they're just like, we got to give her something to talk about.
Yeah, and they can stop anytime soon. They can stop because, you know, I enjoy helping others and stuff, but yeah, I'm just ready for it to feel full healing.
Yeah, I do not blame you.
Yeah.
Well, what do you think? Should we bring her in?
We should. I think so. I can't wait to meet her.
So without further ado, let's introduce Dr. Towfigh. Dr. Shirin Towfigh is a board-certified general surgeon at the Beverly Hills Hernia Center in Southern California. She is world renowned for her treatment of hernias and hernia-related complications. As a result of her subspecialty, she also sees patients from around the world with abdominal and pelvic pains of unknown causes. Dr. Towfigh has widely published her research in the field of hernias and related topics in peer-reviewed articles, chapters, and her book, The Sage's Manual of Groin Pain. She is also the founder of Hernia Talk, a patient discussion forum with a weekly live Q&A session on YouTube. So welcome, Dr. Towfigh.
Thank you so much. Such a pleasure to be part of this.
We're so happy to have you.
Me too. I'm happy to be here.
Yes, thank you. Thank you for saving my girl.
Yes. She did very well.
Yeah.
Let me lead you in with I found Dr. Towfigh while I was on my back in the ER for the 4th time, and they just had absolutely no answers for me. And I just Googled mystery abdominal pain in women because I was just like, they're missing something. And the first article that came up was actually the New York Times, and it was called In Women, Hernias May Be Hidden Agony. And it was this article about how women were going 5 or more years having hernias that were going undiagnosed. And then they came to you and you were able to give them a diagnosis pretty quickly. So yeah, why don't you start off by talking about how you got the call from the New York Times to do this?
Yeah, it's really great. I would say that article was a very, very well written article. It was based on a patient of mine. And, I decided to be a general surgeon because I enjoyed saving lives. And then I developed a subspecialty in hernia surgery. And because I'm a female, I think I started seeing more women patients, and the gynecologist would send me patients. And then I figured out over time that women are different than men, which obviously we know that. But from a hernia disease standpoint and the pelvis, we have different anatomy. In the abdomen, not so much. An appendix is an appendix, whether you're female or male. But the way that you present with hernias and other pelvic disorders are very different in men versus women. And I started to notice that change, that difference, as I saw more women. So if you look at all patients in the world, the ratio of male to female hernias is dramatically on the male side. So if I were to see the same ratio as a population, I should be seeing about 7 or 8 men for every 1 woman that I see, but I see a little bit more than 50% women in my practice.
Wow.
And so because of that, I started seeing trends in women. So if you don't see women that often, then you don't understand that how different they are. You only see the easy patients. And so with time, I figured out that women present differently. They have different symptoms. They almost never have a big bulging hernia in the groin, whereas men tend to. And the pain is almost the primary problem, whereas men, it's not pain. It's usually the bulge. So women tend to present more with radiating pain, like into their vagina. It's worse with their period. So oftentimes they're sent to the gynecologist, and we call it bikini medicine. Have you heard that term?
No, I've never heard of it.
If you're female and you have problems, it's either your breasts or it's your vagina and kind of the female parts. It must be the ovary. It must be endometriosis. Maybe you have fibroids. So women are then labeled with something called chronic pelvic pain. And it's the craziest diagnosis. It just means you have pain. Like there's no definition besides that for chronic pelvic pain. And I tell you, for so many decades, women are living with this diagnosis. Oh, it's in your head. You're going to have to live with it for the rest of your life. But there's so many causes for chronic pelvic pain, and hernia is one of them. And because I'm a general surgeon, not a gynecologist, our worlds don't interact as much as they should. And so once I started breaking those barriers, and I work with urologists and gynecologists and pain doctors, physical therapists, orthopedic surgeons, spine surgeons, all of these specialties overlap. That's when you start seeing how many patients maybe a general surgeon sees and says, oh, it's not a hernia, I don't see a bulge. Or the gynecologist see it and say, oh, your ovaries look fine, and you didn't get better on birth control, so it's not endometriosis. So having a more like a horizontal approach versus a vertical approach is something that, especially in the United States, we don't do very well. But I'm lucky in my practice I've done it. So when I saw you, you had, how many years was it that you had problems? You were in the ER a couple of times.
Yeah. By the time I saw you, I had been in the ER 4 times.
Yeah.
Twice was back to back because I was just in so much pain, and I I thought that I just like pulled my groin because it was radiating down my leg.
Yeah.
But after trying to do my own physical therapy with my trainer, one day he put his uh, push pressure point that shot up my abdomen, and I turned green. And I just looked at him and I was like, "Well, what side is your appendix on?" And he was like, "That side." And that's when I went to the ER, and I knew that there was something more than just a muscle wrong.
Mm-hmm.
And it's so funny that you say like women present with pain, men present with a bulge most of the time. I understand that's not everybody, but the every doctor I went to before I went to you, I would not test me for a hernia. I actually had a doctor uh like rub in between his eyes, and he was like, "I need you to point to where it hurts and don't point to where you think you have a hernia." And I was like, "Oh my gourd." And this was like a doctor I waited 2.5 months to see.
Yeah.
So, it was when I found you, it was awesome because I mean, at first we still thought it was muscular, and we tested me for hip issues.
Yeah. Yeah, there's a lot of overlap. A growing pain can be from your hip. It can be a hernia. It can be a weird appendix. It could be Crohn's disease with a mostly like problems in the right lower abdomen where you can get inflammation of the appendix or the cecum. Of course, it could be gynecologic. So, for example, like an ovarian cyst, it can be endometriosis. There's a lot. It can be from your spine where you have a pinched nerve that radiates into the groin. It's usually higher up in the lumbar
Mm-hmm.
area than the typical like sciatica pain. So there's a lot of overlap, and most people can't keep going to like 5 different specialists. So I kind of learned to be like the team captain and like, let me figure it out for you. And
Yes.
then we'll go through, okay, so now you have to see colorectal surgeon, or now you have to see a gynecologist
Mm-hmm.
to get the definitive treatment. So I love that about what I do, but I know that it's not an easy way to practice because at least US medical care doesn't support like sitting down, thinking, and spending a lot of time on one problem. It's, patient after patient after patient, 10 minutes,
Volume.
15 minutes. It's a
Yeah.
volume based medical practice in the US mostly.
Yeah, that's
And it's so interesting, like that they just kind of, it seems almost if they put a band aid of, that pelvic pain diagnosis over it. Cause you just named off, I would say, like 7 or 8 different things that it could be. And all of those would be treated completely differently. So it's just kind of interesting how that works, you could say.
oh for
Right. So
sure.
if you're not really good at being exactly like giving all the details and your doctor's not able to sit down and listen to every single symptom that you have, and if we don't even teach it in medical school, so that's one thing that we're trying to change is how students are taught in medical school about hernias. Hernia is the number one most common procedure done by general surgeons in the world. Number
Oh,
one, so common. Every
Wow.
single surgeon that graduates from residency needs to know how to fix hernias. We do over 1 million a year in the United States. So to most likely, there are tons of women out there with chronic pelvic pain that have hernias that are not diagnosed. And it's not taught in medical school. I've looked through all the books that are currently being used, the ones that were used. We had Barbara Bates. She's like the main author of how to do physical exam and so on. And it just doesn't teach you what I've learned. So our goal now is to change how my residents learn, so they can go out and practice, and then hopefully change how the medical school teaches about women, how they're different in their pelvis, and therefore how they present differently with pain, and stop using this basket diagnosis of chronic pelvic pain. Because I'll tell you, we just finished a study. This is like breaking news, sort of, but
Ooh.
You heard it here
hasn't been
first.
published yet. You've heard it here first. But in our study, looking at the women, they were diagnosed 1 year later than the men. So they basically suffered for 1 year longer than men for their same problem, inguinal hernia. And most importantly, a large percentage of them were on opioids, whereas the men were not. So you're already submitting women to opioids and maybe opioid, um, uh, basically dependence. And
Yeah.
right?
Yeah.
You raised your hand about that.
Yeah, when you saw me, I was on opioids because they gave them to me in the hospital. My pain level was through the roof. I thought that it was really the only thing that I could do at that point to manage my pain. And I was taking them very sparingly, but they jacked me up.
Yeah.
They
So
made
that's totally preventable.
yeah.
It's totally preventable. You may recall many years ago, women were dying of heart attacks. And they found out that women present differently with chest pain than men. You remember that?
Yes.
I actually just did a story on that for the news. So I'm a news reporter as my real day job, and for Heart Month I actually did a story about that. It's
Yeah.
very
That's crazy.
interesting.
So they found out women complain of like, oh, a little heartburn, or the pain may be on the other side of the heart, like right jaw instead of left jaw. Um, and so they were not diagnosed, and they were given some Tums and discharged, and then they would die. Whereas men were rushed to, getting their cardiac catheterization or whatever it was. And I feel that hernias are similar. It's like the cardiac angina of the pelvis, where women present differently, and their outcomes are also different because of how the enormous delay they get in their treatment.
Now, what are some of the different ways that women present with hernias
So
from men?
specifically inguinal hernias or groin hernias, they often have groin pain that's activity related. So when they're sitting, it's worse, bending, stairs, coughing or sneezing. And then the pain radiates from just above the groin crease into their vagina to their inner thigh or around their lower back. So they have radiating pain, whereas men often don't have, they just have pain localized to the area. They may get bloating. It's worse during their menses or their period. So these are all details of the story that it's really great to capture. Most people don't ask these questions. But once you do, then you'll see a pattern. A lot of women have the same symptoms over and over again as you see more and more. Whereas the man may say, oh, I have this bulge, I think I have a hernia. And they're able to go to the gym with no problem and so on. Also, you have pain with intercourse can be painful, and orgasm can be painful. So it affects the quality of life in multiple ways.
That sounds so much like what I was experiencing.
Mm-hmm.
And yet, over and over again, I had a doctor place his fingers on my stomach and ask me to cough.
Yeah.
Well, sorry, on my groin area,
Yeah.
and ask me to cough. And then they were like, well, we don't feel anything.
And therefore you don't have anything. Yeah.
Exactly. So if you're a female or a male and you suspect that you have a hernia, what kind of tests do you recommend that they ask their doctor in a proactive way?
Right. So that article is very helpful. I have a lot of patients that take that article to their physician and say, what about
Yes.
this? I have all these symptoms. It sounds like this article was written about me. So push the doctor. And, in the United States, we have a lot of options for medical care. You're allowed to see more than one doctor. It's not a socialist system where it's a little bit more restricted. So if you go to your doctor and they're open-minded, they're willing to at least take you through the process to either prove or disprove that you have a hernia, then that's great. But if you get pushback and they're not listening to you, by all means, go see a second doctor and find someone who will listen to you to at least look into it. Of course, not everyone has a hernia as the cause of their pelvic pain, but a very large proportion in women especially are missed.
Well, I know that like when I came to see you, I had already had multiple CTs.
Mm-hmm.
And in a CT, they couldn't find it. But we were able to find mine because it was very small
Yes.
and it was direct, not indirect,
Yes.
right?
Mm-hmm.
We were able to find it from an MRI.
Correct. So
Yeah.
hernias are not the most glamorous part of general surgery. We're not, doing heart surgery or like brain surgery or saving like a trauma gunshot wound. So unfortunately, it doesn't get as much credit, even though it's so common. Um, so when an ultrasound, CAT scan, or MRI is performed, which are the three types of imaging you can do for hernias, often the radiologists don't give too much credence to a hernia either. So they'll look for tumors and cysts and growths and abnormalities. But we looked at our data. I looked at all the imaging that our patients came with, and then how many of them had surgery to compare the findings in surgery versus what the report by the radiologist was. And 3 out of 4 imaging studies were wrong. They either didn't mention
Wow.
anything, didn't even say yes or no hernia, or they said there was no hernia when there was a hernia. So again, we're working with radiologists and publishing in their world to help give them a little bit more insight into what we surgeons see as hernias to improve their ability to read more. So the radiologists that I work with at Cedars-Sinai Medical Center and the affiliate radiology centers around my office, they know when I send in a report, they'd better take a good look at for hernias, and they've learned to do a very detailed job specifically of the pelvis. But we're slowly expanding that by publishing and giving talks, and hopefully that will disseminate through.
It's interesting that doctors aren't really trained to actually take that extra time to really look for them.
Right. So CAT scan for general surgeons, CAT scans are fairly easy to read. We do it all the time, and it's part of our training. Most general surgeons are comfortable reading a CAT scan, and if they choose to look at the imaging themselves, they will probably find more than the radiologist does in the groin area because they've examined the patient, they know the story, so they kind of look in more detail. The problem is many people just have like the report. Like my office knows to go the extra length and actually get the physical CD burn of that imaging for me to look at myself. But it's much easier just to get the report faxed to you or emailed to you. So most doctors will see the report, and if the report never says anything, then that patient can go for years not getting a diagnosis because the doctors will just look at the report and say, oh, there's no hernia. Whereas that was a mistaken report, basically. MRI is different. MRI is very difficult to read. I had to learn how to read it by sitting down with our MRI specialist radiologist. And so now I'm really good at it, but it takes extra effort to do that. Same with ultrasound. It's hard to read the imaging. So you're very dependent on the radiologist getting it right. So what I tell when we talk about this is, fine, you're not the best at reading radiology because you're a surgeon, but at least if the patient's story sounds like it may be a hernia and the exam is not perfect, but there's definitely pain where a hernia would be, then go back and either on the phone or sit next to your radiologist and the two of you review it and you explain to them what you've examined, and the radiologist will reevaluate and say, oh yeah, I guess you could say there's a little hernia here, and that will help your patient much more than just assuming that the radiologist is always correct.
I hope that we have some doctors tuning in because that is just super helpful information of
Yeah.
a new way to collaborate, I guess. I
Collaboration,
mean,
yeah.
speaking of that, I mean, we we didn't find mine even off the bat when we had our first MRI either. You had to go back and look at it. I think you might have gotten back to me a month later when you were like, "Wait a minute, I think I found it."
Yeah. Yeah, I had to re-review it.
So
Yeah, because the
they
CT
are
scan,
really difficult to find.
yeah, the MRI is much more sensitive than a CT scan. But
Hmm.
yeah, you just like learn over time to like how to read it. But MRIs are difficult to read.
Yeah. Well, speaking of that, could you kind of explain the story about how we got from hip pain to hernia to possible volvulus? Because
Yeah.
that was just like, that was the key that unlocked everything that got me from the crumpled ball, because I couldn't even sit with my legs extended. I was like in a ball on your table, from that to like here I am bubbly and like finally back to life, all from like this moment. So could you please share with everyone how we found the miracle?
Yeah, well, a lot of it was because of you. Well, you're very thin. Well, that helps because you can see the anatomy much more clearly. And then you had pictures. You had pictures and maybe even a video of how your stomach would bulge on one side when you got these attacks. And, you didn't necessarily have that when you came in to see me or a doctor or maybe even at the ER. So at the times when you had those episodes, you videotaped or took pictures of yourself to prove and document. And that was really helpful because based on where the bulging was, I could say, okay, that's not a hernia bulge. It's higher up and more to the side than a hernia bulge would be. So let's see what else it can be. And usually that area is where the colon starts. It's the cecum. And there are only so many diseases that occur in the cecum, and one of them is a bascule, and the other one is a volvulus. And those are just two different ways where the cecum kind of folds on itself. It either folds or it twists. A bascule is a fold, and a volvulus is a cecum, is a twist. So that's a surgical problem, and imaging often misses that because unless you're actively twisted during the time of
Hmm.
the imaging, you're not going to see it. It's like those, those toy balloons. Like people make little toys out of balloons, those long balloons. You
Yes.
twist them around,
Yes,
but
the
it's
balloon animals.
the balloon animals.
Yeah.
So that's what a volvulus is, or maybe perhaps what you had when you were 17. But if you do look at it when it's untwisted, you can't say, oh, that's like a dog or whatever they make the toy out of. It has to
Hmm.
be at the time of the twisting. So in the OR is when you can determine if it's a floppy cecum, which means it's like extra long or not. So it's extra long so it can fold onto itself. Like think of like toast versus like a baguette. Baguette you can probably fold onto itself because it's long, but toast you can fold, but it's like not as easy. Um, or in surgery, you can identify if the colon is not attached to the abdominal wall like it should be. And so it makes it more floppy, so it's more likely to twist around itself.
Hmm.
Your ability to kind of engage and kind of be your own advocate was, I think, the most helpful by taking pictures and showing the pictures and not being shy about pushing the story.
I'm glad you said that because I feel like that's a detail of the whole thing that I kind of forgot about. A lot of times when you go undiagnosed and can't really figure it out for a while, you start feeling like you're crying wolf, and that,
Yeah,
like you mentioned, like everybody says it's in your head. So, I mean, I took
yeah,
those videos not thinking that they would necessarily help out, but to prove like I have a high pain tolerance and I'm pretending to have it together, but I am awfully sick and this is not normal, and this is me when I'm terribly sick and I'm growing an alien. uh, so thank you for reminding me.
yeah. You can't fake growing the alien like that kind of bulging. You can't fake, and there's I never think that patients fake things or tell lies. That's I'm sure a small percentage do that, but the 99 point plus percent of patients don't want to be sick. They don't want to have pain. They don't want to be in the emergency room.
Mm-hmm.
So, and you had a physically changed. You can't fake that. When you have a picture, that has to like push someone to start looking more in depth and figuring out what you have. What you had was rare.
Mm-hmm.
That is it. So your doctors need to be aware of some rare diagnoses to be able to help you, but it was real.
Yeah. And you know, another detail that I remember you showed me too was that it was like the shape of my bladder was different.
Hmm.
And
Yeah,
so you thought that that was also kind of showing in the imaging that there was something abnormal going on with the intestines.
correct. So when you have your bladder is like a sack. So when it fills with water, it should be perfectly circular, basically. So the more your bladder fills, the more kind of round it becomes. But if it's indented on either side, it's because something from the outside is pushing in, and that could be your ovary or fibroid. It could be a large piece of intestine that's sitting on your bladder. So all of those are little clues on imaging that shouldn't be discounted as just, oh, like bladder looks normal. Yeah, not really. It's kind of asymmetric. So let's see why that is.
Mm-hmm. So if somebody suspects that they have a hernia, where should they start the process in getting diagnosed? And what are some things that they should do in the meantime to alleviate the pain besides taking painkillers? Because uh, that's like absolute last resort.
I feel like that can even like increase the hernia, right? Because it slows down your system, the
Yeah.
opioids.
I mean, that's what it did for me. It made mine 10 times worse because it constipated the heck out of me, which just blew
Yeah.
everything up in there.
Yeah. Constipation is the enemy of hernias. It's the number one problem in the United States, and people that have hernias, they're all constipated, they're straining,
Ugh.
that increases abdominal pressure, and that makes you more prone to having symptoms from your hernias and hernias bulging out.
Mm-hmm.
So that's a great question. First of all, the pain from hernias, regardless of where your hernia is inflammatory pain. It's due to inflammation in the area. So any anti-inflammatory works. Narcotics and opioids, by definition, have no anti-inflammatory property. It just numbs the pain. So you need ice packs, I think is the best. It's a great anti-inflammatory, works really great for hernia pain. And then secondly, anti-inflammatory pills. So that includes like ibuprofen, naproxen. Those are the over-the-counter ones, so like Aleve, Motrin, Advil, that type of pain medication. And then thirdly, you can use natural herbal supplements that are anti-inflammatory. So turmeric, ginger, arnica is a good homeopathic that has anti-inflammatory properties.
CBD?
These are all over the counter. Yeah, actually, the CBD itself has good anti-inflammatory properties. So you can get CBD orally as a pill or a droplet, but also they come in patches. You can put it right over the area, and you can also there are creams that have high CBD content. It has to be not the hemp CBD, but the real CBD that has the good properties.
Interesting.
Yeah, CBD is great.
Informed on the CBD. I love it, Dr. Towfigh.
Yes.
I went to a local dispensary with the office. I'm like, we're going on a field trip, guys. Let's go. We gotta learn. What's out there.
It's a new age.
And
I
yeah, we
love
went.
learning
And,
about marijuana, and
uh-huh.
it's I don't really like the THC as much, but just for the CBD properties for inflammation, I swear by it. I mean,
Yeah.
I've got the salves, I've got the drops. I love it. And for my anxiety too, because I get anxiety from inflammation in my gut still.
Yeah.
So when I get like a bad flare up, I get anxiety, and it helps me with that too without, giving me all the head stuff.
Mhm.
I have got to say, so I got a pedicure 2 days ago, and the
Yeah.
salon that I went to had, some like bath salts with CBD in it. And they're like, I'll put this in there. And I'm like, okay, sure, go for it. I fell asleep during my pedicure. It was very relaxing. Like, it, like, so, like, I was out. So,
Yeah, the CBD market has really improved. There's so much more research being done now. And I used to be able to buy pure CBD, but I think, especially for the creams, but now you have to, I think, I don't know why, but they all have a touch of THC at the very least. So I'm told that the THC does enhance the CBD properties. It's definitely not enough to make you high, but I don't know why they're no longer selling pure CBD creams. I need to read up on that.
Yeah, I heard that the THC does enhance it too.
Yeah.
Because I've been doing research on that, specifically like for my grandparents who have been having back problems, like sending them a
Oh yeah.
salve that they can use, and it's not like
Yeah.
dope as they know it, you know. And I tell them afterwards, like, oh, it's got a little THC in there. Sorry.
Oh, so for my mom's birthday, I bought her like a whole range of CBD cream products that come in roll-ons and salves, like you said. And I kind of also used her as my, like, which one did you like the best? And which one worked on your joint pain and your back pain? And so I can use that information for my patients. But yeah, she loves it. It worked really
Smart.
well. Well, yeah.
Okay, so now we know what we could do to help with the pain. What are
Mhm.
how do we start the process of uh, getting a diagnosis and getting help?
Most people will start with their primary care doctor or their gynecologist if they're female, and that's their primary care doctor. Uh, Really, if there's any pain in the groin level, and that basically is if you feel your the bone in the middle of your lower abdomen is called the pubic bone, and then you feel the kind of side hip bone, anything in that region just above the groin crease should be considered for hernia. And if your medical doctor can initiate the studies, like the ultrasound usually, I don't recommend CT scan. I go straight from ultrasound to MRI if that's unhelpful, but that's kind of my specialty. But at least start with an ultrasound. And it has to be a hernia ultrasound. You can't do it via gynecologic ultrasound, pelvic ultrasound, or abdominal ultrasound. It has to have the word hernia in it. Um, so that's where you would start. If they're not comfortable making that diagnosis, they should refer to a general surgeon. And then if that doesn't work and you still think you have something, then you should find a hernia specialist. There's a handful of us are sprinkled around the United States and the world. So if you go on herniatalk.com, there's a list of many of us. Some of the Facebook groups that deal with kind of pelvic stuff have a lot of our names. The American Hernia Society has a find a surgeon tab where you can just put in where you live, and some members of the American Hernia Society will pop up near you who have an interest in hernias.
so what sparked your interest for in the first place with the hernias?
That's a great story, actually. I'll make it brief. When I was a resident, I had zero interest in hernias. Again, it's never something that's promoted during residency. It's kind of like, oh, yeah, do a hernia, but it's not considered a high level. It's not like doing like pancreatic cancer surgery, which was what I actually really enjoyed doing. And then I my first job was at USC and at the LA County, Los Angeles County Hospital, which is like a general hospital. If you ever watch General Hospital, the
Oh
actual
yeah.
soap opera, that's General Hospital. It's the actual LA County USC hospital. Um, it was a great place to work. It's the largest county hospital and busiest in the nation. And my first patient was a lady with mesh infection.
Ugh.
And so I treated her. And she was bouncing around from like general surgery to gynecology and back because it was a hysterectomy incision that got infected. And no one took ownership of her. So I fixed her. And then I started doing more and more of the hernias. And I became like They were called Towfigh hernias. So the residents, I'm like, I need to learn more about this stuff. So I started getting involved with the American Hernia Society, and they're a great, great group. I'm still very much involved in them. I was involved in their leadership for a while. And by 2000, so that was 2002. By 2008, I said, I just want to do this for a living. And so that's what I've been doing ever since.
Awesome.
When you were on the when you first joined the board, there weren't very many female surgeons doing this at all, right?
No,
Isn't
my
that the
first
story?
meeting at the, yeah, that's a good story too. So in general, there aren't that many female surgeons. General surgery, I think at the time when I graduated, I think it was 12% were females and 25% in training.
Wow.
And I went, and hernias, it was close to zero. So I went to my first hernia meeting, and I literally opened the door to the auditorium to join. And all I saw were, and I don't mean to be demeaning in any way, but old men with either white hair or no hair, because I was just from the back, right? You just see them from the back. And then
Yeah.
I was the only female that was presenting, but they were so kind. One gentleman came up to me and said, it was great talk, really great to have you. Would you like to be on our editorial board for our journal? I was like barely a year out of residency. I'm like, hell yeah, of course. You always say yes to opportunities.
Yes.
He said, we've never had a female before. So the fact that he actually thought that was important, I thought was great. It's 2002. Yes. And then right after that, I got on the board. So I served on the board I think it was 2 6-year, so 3 and 3, and then a little gap, and another 3 and 3. They brought me back on the board, and that was really great. And I do so much patient advocacy now. It's a lot of what I do with Hernia Talk and kind of promoting the needs of patients, that I've kind of developed a niche within the board as like the voice of the patients, to kind of represent the patients as much as possible and make sure they're always part of what we do as a society. So yeah, we have more women now. We had our first female president 3 years ago. So
yes,
very cool.
That's the conversation I listened to. That was the one.
Yeah,
with her.
Yeah, with Dr. Andrelas. Yeah, she's great.
Mm-hmm.
So if anybody wants to, come see you if they think they have a hernia, or if they want to find you, how can they find you?
Yeah, so you can go on Hernia Talk or find me on any of the social media avenues. I'm known as Hernia Doc. So if you go at Hernia Doc on Twitter or Instagram, you'll find me there. I think it's Dr. Towfigh on Facebook. Or you can just go to herniatalk.com, and I'm usually on that discussion forum.
Awesome.
Oh, well, thank you so much for being with us today. This was, more interesting. Who thought that hernias could be so interesting to the layperson? I learned so much.
I did too, and I think my favorite, like, the best analogy is the balloon animal thing. That really kind of puts volvulus into perspective. So I never thought of it that way. So that's a really big takeaway for me, at least. Yeah.
Yeah, you gotta, I love analogies, so I try and come up with interesting analogies.
For sure.
Yeah, I think hernias would be so interesting. I mean, it's become like my life, and I love it. I wore my God Hernia t-shirt for you guys.
Let's see it.
Oh, yes.
I love that. Oh my gosh, we need those.
I'm past due for one, so I need to come by mine.
Sure. Happy to do it.
Yes.
Awesome. Well, thank you so much for being here with us today.
Yes, thank you. And it's so great to meet you, and for everything you've done for Nicole. Thank you so much. If she wouldn't have made it through, I would never have met her, and it's because of you. So I appreciate you.
She's a trooper.
Yes. Thank you.
Glad to see her doing so well.
Thank you so much. You are my angel, and you inspire me in so many ways. So I will forever be your cheerleader.
I love it, and I love seeing all the work that you guys do, both on the podcast and in your own careers.
Thank you.
Thank you.
Thanks, guys.
Well, that is today's episode of Girls with Guts, or what's left of them. So until next time,
Stay bold
stay gutsy.
and namaste.
See you next time.